of contrast-enhanced digital mammography. So mammography still remains the most widely used examination for detecting breast cancer. However, mammography, as amazing as it is, it does come with its share of limitations. And we are all aware that the breast is composed of adipose and fibroglandular tissue. So normal glandular tissue of the breast is white, and unfortunately, so is cancerous tissue, making cancer detection challenging, particularly in dense breasts. So in dense breasts, it becomes very difficult to detect cancer against the adipose tissue, and that's why in BIRAD's C and D densities, cancer detection is very challenging. Yes, we have 3D tomosynthesis now to overcome this, and in addition to that, now I'm going to talk about functional imaging to overcome the same limitations. So this particular contrast-enhanced digital mammography is very, very useful for dense breasts. So breast imaging evaluation, it involves two processes. One where we assess the morphological characteristic of a tumor, where X-rays and ultrasound waves are used to assess the physical activity of the breast, and it comprises of mammograms, ultrasound, and tomosynthesis. The other process where we assess the functional characteristic of a tumor, where it comprises of MRI and contrast-enhanced digital mammography. So what is contrasted mammography? Basically, it is a mammogram done after IV injection of contrast media. So it is a relatively new technique with FDA clearance as recent as 2011. It provides us physiological information from the increased uptake of contrast in a tumor, and it complements the morphological information obtained through mammograms. Additionally, it is unaffected by the density of the breast. So I'm going to just touch a little bit on the physics so that you can understand what I'm talking about in the other slides where there's low and I'm going to keep mentioning low and high energy images. So that's why I'm going to mention a little bit about the physics on how we obtain this beautiful image of the biological activity of the tumor in a mammogram. All right? So this is the basic of contrast imaging in all CT, be it CT scan or any contrast imaging where we use iodinated contrast. We use this graph is a radiological graph where at 33 keV there is a phenomenon known as a photoelectric phenomenon. Below the 33 keV, keV is the X-ray energy that we throw out. All right. So below 33 keV, the breast tissue is well seen, and the iodine concentration in the breast is very low. Then reaches 33 keV where the attenuation of iodine dramatically increases. That is the whole concept of contrasted imaging in radiology. So it dramatically increases, and above this level, the iodine content is very high, and you get basically an iodinated image, and the breast tissue is very little in the images after that. All right, you hardly see much of the breast tissue. So what contrasted mammography does is it makes use of this dual energy procedure. It takes advantage of the photoelectric phenomenon. So it will give us a low energy image, which is basically a standard mammogram, all right, and a high energy image, which is an iodinated mammogram. And they do a log algorithm to subtract both the images to obtain an image with a relative distribution of iodine in the breast. So you get only the leaky vessels in the mammogram. And this is how we do a contrasted procedure. This is our setup in Italy. The patient will be seated on this chair. There is an injector not far from the patient, and that's our mammogram machine. She needs to be seated close to the mammogram machine because after IV injection of contrast media, she has 2 minutes to be able to walk to the mammogram machine to start her mammograms. So just like how we do a CT scan, the same procedure happens here. We have to check for allergies, check for renal sufficiency. The patient requires an IV line. She needs to be seated for administration of IV contrast. So this is how the patient is seated, and she's receiving IV contrast via power injector. And we basically use contrast at a dose of 1.5 cc's per kg body weight at a rate of 3 cc's per second via a power injector. it is very important that when the patient is receiving this contrast, the breast is not compressed, because if the breast is compressed during this time, contrast is not going to flow sufficiently into the breast for us to be able to obtain the images we want. So the patient has to wait exactly 2 minutes before we start imaging. So our system comes with a very beautiful timeline, which the radiographers will have this entire timeline in front of them, so they know that this is where you start the injection. They've got 2 minutes to remove the injector, and the patient is able to walk to the mammo machine during these 2 minutes of the yellow phase. From these 2 minutes at this green zone, they start imaging. So we do the same for standard mammographic views. At each view, just now I had mentioned about low and high energy, at each view a low and high energy image is taken in rapid sequence. So we do the 4 standard views, and these are the images that we will obtain. The low energy image, which is basically a standard mammogram. A high energy image, which is the iodinated image, and the subtracted image is obtained by the machine doing a logarithmic subtraction. The only thing that's sent to the PACS would be the low energy and the subtracted image. So basically what you get is a standard mammogram and a subtracted image. So what is the radiation dose issue here? Yes, there is a slight increase in radiation dose, but if we are very smart in how we do this procedure, is a very, very low amount of radiation that we add on. The only added radiation would be the high energy, because the low energy is really a mammogram. So you don't actually have to do a mammogram if you're going to do a patient which has a very suspicious mass. So I work right now in HKL, we are a tertiary referral center. So what we have is on Tuesdays, we have walk-in clinics where our surgeons get all these malignant lesions referred to them. And they give us a call and they said, okay, this patient has a very suspicious lesion. And just to make sure when they come to our unit, sometimes I will just make sure that I will put a probe on it to make sure that we are not dealing with a cyst and we are dealing with a mass. And the patient doesn't even need to be seated, we just put the probe there, okay, it's a mass. I would straight away, instead of doing a mammogram first, we would just sometimes proceed directly to a contrasted mammogram, because the first image that we obtain is really a mammogram, the low energy, and after that we get a contrasted mammogram, and it makes it so much easier for us to do an ultrasound after our contrasted mammogram in these patients, because any other lesions other than that big mass enhancing, we can take a biopsy immediately. So we become very much more confident in our post-mammogram ultrasound when we do it directly. So it also saves radiation dose to the patient. However, I did ask our physicists, our vendor physicists, on how I can tell you all what the radiation dose increment is in layman's term. He said taking a standard mammogram 2D as 1, contrasted mammography is 1.25. So it's just a 0.25 increment in the radiation dose. And then again, we are doing this in a select group of patients who are actually breast cancer patients. We are not doing it in screening yet, all right? So there's another thing called a combo procedure where we add on a tomo that's mainly for architectural distortions. Of course, in that one, the dose goes up to about 2.5 times the standard mammogram. However, in all 3 procedures, the radiation dose does not exceed the ACR limit of 3 milligrays for a single mammographic view. So it's still within the recommended doses. So the pink line, the pink dotted line, is a normal 2D, which we do, it's a normal mammogram, and the blue line is a contrasted mammogram. So it's slightly increased, but still within the dose limits of the ACR. ACR is the American College of Radiology. I've put up this slide because it was done by Mayo Clinic in June last year. It's about the cost, how much we save, because basically contrasted mammogram is giving us the same information as an MRI. They are both functional imaging. So in the study that was done in Arizona, Mayo Clinic, Arizona, they said that there was an 80% reduction in the cost when we did contrasted mammogram in comparison to MRI. And when I was at Italy, we did an estimate, and a breast MRI cost euros 245. However, contrasted mammography only costed 95 euros. There was a 40% decrease in the amount spent for a contrasted mammogram. In this study, they also said that the reduced exam time was so much better in a contrasted mammogram, 10 minutes compared to 30 to 60 minutes for a mammogram. there was increased access because basically it's just a software upgrade of your mammogram machine. So every mammogram machine that comes now, most of the mammogram machines are going to come with this facility to add on a software where you can get contrasted mammography. Of course, it's the newer machines. And the surgeons, if you see this line, they found that the breast clinicians, particularly the surgeons, really liked it because of the ease of interpretation. You can see the lesion is either there or not there. So it's not like an MRI, sometimes you have to differentiate between the benign lesions and the malignant lesions. Yeah, benign lesions do enhance, but this one is usually quite straightforward. All right, and the patients are able to see their results the same day. So what we do is, the unit, we have an ultrasound machine in the next room. If we find anything enhancing, the patient is immediately called in. We do an second look ultrasound immediately, not like an MRI where we have to call the patient back after 2 weeks. And this one we do it immediately, and we biopsy the new lesion that's enhancing immediately. So within a few days, within 2 days later, the patient's got the biopsy result of any other multifocal lesion that's detected on the mammogram. So this is some of a recent study done by a friend of mine, John Lewin, and the comparison between the advantages of contrast enhanced compared to an MRI. Well, it's lower cost, shorter examination time, and you can actually detect calcifications because you have a complementary mammogram with you, which is something that you can't do with the MRI. And you don't have any issues of claustrophobia, and even the other MRI contraindications of pacemakers and all doesn't come in place here. And there's no risk of NSF or gadolinium deposition with contrasted. So what are the indications? Is to do it for evaluation of difficult to interpret mammograms, problem solving, identifying potential undetected malignancies, evaluating the extent of disease preoperatively, which is one of the main reasons we do it, assessment of response to chemotherapy, and patients contraindicated to MRI. I'm going to go over each of them. Problem solving, this was the case with inconclusive mammographic and ultrasound findings. There was an increased asymmetric density seen at this region where the arrow is pointing, but we couldn't find the lesion on ultrasound. She was one of those ultrasound unfriendly breasts, and it was intensely enhancing on contrasted mammography. So this was an infiltrating carcinoma. Of course, on second look ultrasound with measurements and everything, we tried to isolate the region. This was a patient who had bilateral microcalcifications, which was increasing. She was on follow-up, and it was increasing in number. And so we decided to go contrasted. As you can see, despite her breast being very dense, this is a type D density breast. We managed to suppress most of the density, and you get this. Of course, there was a rim enhancing lesion in the left breast. Otherwise, the areas of calcification did not show any non-mass enhancement. And once again, in the MLO view, we saw that rim enhancing lesion. We did an ultrasound. It was basically just an infected cyst, but the calcifications did not show enhancement. We could safely tell this patient, you are free to go. You don't have to worry about these calcifications in your breast. So this was another one. In these kind of cases, what would we do as radiologists? We panic. We'll tell them every 6 months, please come for that compression view because she's got an asymmetric density in the left breast. And the normal follow-up for this, we would label it as a BIRADS 3 and tell her to come 6 months, and we will compress it and we'll repeat it, and she'll have to do that. There'll be another radiologist and they'll just keep doing that 6 months thing, which is an added radiation dose to the patient. But we did a contrasted mammogram, and we could tell her, you don't have to come every 6 months, just come back after 2 years for your normal regular follow-up. So this is no malignancy and an asymmetric density. In search of a primary cancer, these are patients who are referred to us for lymph nodes in the axilla, and they can't seem to find where the lesion is. This was a case, and we saw an asymmetric density here, and you can see she's got a lymph node. It showed beautiful enhancement with the contrasted mammogram, so it solves a lot of problems. Local extent of disease. So this was a patient, this is a 53-year-old female. She had a biopsy-proven infiltrating carcinoma in her lower inner quadrant of her right breast. She was referred to us for preoperative staging. So that it seems like it's just isolated to the lower inner quadrant, right? And the 3D didn't give us that much added information. But look at what the contrasted mammogram gave us. It showed us that it's not only involving the lower, but it's going all the way to the upper quadrant to involve almost the entire breast. And in her volume, it would definitely change the management for her. So it indicates multifocality, that is actually multicentricity. So this is another patient with a biopsy-proven infiltrating carcinoma of the right breast, referred for preoperative staging. This is the 2D and 3D mammograms, and the contrasted mammogram showed us another lesion about 2 centimeters away from the primary lesion. She was going to go in for a breast conservation surgery. At least the surgeons found out that there was actually another lesion that they have to tackle approximately 2 centimeters away. So it changed her management. So indicating multifocality again. Another patient, right breast, proven infiltrating carcinoma. We can all see, everyone knows that lesion is there. There was another, and it was showing enhancement in contrasted. There was no other lesion in the right breast. However, we saw this area of increased density, which we couldn't identify on the ultrasound. And we managed to get enhancement in the contrast-enhanced digital mammography. So in these kind of cases, we will measure how far the lesion is from the nipple, and we will do a very, very close second look ultrasound to look for the lesion. And we found it, and it turned out to be an infiltrating carcinoma in the left breast as well. So in bilateral disease. So local recurrence versus scar. This was a patient with an increase, so she was on follow-up for post-breast conservation surgery, and she had this increased density, linear density posterior to her surgical clips, and there was also calcifications increasing in number in that area, so we were not too sure what was happening. We did a contrasted mammogram. This is a bit off because this is where I'm going to talk about the early and delayed. This is a mammogram done in the contrasted mammogram done in the early and delayed phase. If you see, it is actually enhancing more in the delayed phase, which on MRI as well, when it comes to functional imaging, if it enhances in the delayed phase or is progressive enhancement in the delayed phase, it goes more for benign lesions than malignant, which is the case here, that it turned out to be a benign inflammatory lesion rather than a malignant lesion. So we are trying, this is a study that we are doing to see whether contrasted mammography can actually give us kinetics, which we don't have yet, any study on it yet, any literature, sorry. Neoadjuvant chemotherapy, this is a case before neoadjuvant chemotherapy, during, and was showing good response to treatment. This is a beautiful case that we did in Italy. She was a 62-year-old with an invasive ductal carcinoma. This was an image pre-chemo, and she had one, this was in March 2017. September, it was completely disappeared. We were a bit scared. We were wondering whether the contrast actually went into the breast. We actually did an ultrasound, and there were no lesions seen in the subsequent images. So she actually had very good response to treatment. MRI contraindications, patient with a pacemaker, she had a spiculated lesion, she had a previous history of right breast cancer, she had a post-quadrantectomy, and it showed intense enhancement. So she had a lumpectomy, a wide excision lumpectomy performed, and it was a invasive ductal carcinoma. This is a patient with a BRCA1 mutation. She was severely claustrophobic, and we couldn't put her into the MRI machine, but she had such bad and dense breast. This is a Barrett's D density breast. So we were a bit scared about this kind of patient. She was a 40-year-old, and we thought, okay, let's just put her through a contrasted mammogram just to be safe. And yes, she had no enhancements, so we told her, okay, she doesn't have any lesions to worry about. This is a patient with a spiculated lesion at the surgical site. She had a previous left breast cancer. Spiculation was increasing on routine follow-up, and it showed no enhancement, so we safely could tell the patient that it's just basically post-surgical scarring that's appearing more prominent. So what are the limitations? Yes, the slight increase in radiation dose. Limited assessment of the posterior extent of masses, that's one of our limitations as well, because in MRI you can see the posterior extent, whereas that's a bit of a limitation in mammogram. Lack of technology to biopsy, which is being overcome because there is a prototype being developed in the near future to be able to biopsy with contrasted mammography. So this is an image of posterior extent not being well seen on contrasted, whereas it's better seen on mammogram. Another one. So what are the indications? Like I said, most of the cases we've done, like when I was in Italy, by the time I left, they've done about 985, 67% of the cases were preoperative staging. The rest were 25% problem solving, and the rest of them was MRI contraindication, but a very small percentage for scar assessment and post-neoadjuvant chemotherapy. So this is, I'm just going to go over some cases. So this is case 1. She's a 59-year-old female, presented with a palpable left breast lump. The lesion was not demonstrable on 2D and 3D. As you can see, the breast is rather dense. And We did a contrast-enhanced digital mammography. This is to show how beautifully we can see angiogenesis around the tumor in some of the cases. So that's a tumor with angiogenesis. It shows enhancement in the early phase and in the delayed phase. That's washout. And this was a infiltrating carcinoma. Case 2 is a 59-year-old female. And contrasted mammography was done as a preoperative staging for biopsy-proven left infiltrating tubular carcinoma in her upper outer region. And we did the contrasted mammography, and it shows the area that this was the area where the palpable lump was. Because it's a low-grade tumor, it's actually showing more enhancement in the delayed phase than it did in the early phase. But what we did see was an intensely enhancing lesion at her axillary tail. So we immediately took her down to the ultrasound machine, identified this lesion, and she had a biopsy done immediately. 2 days later, we received her diagnosis as an infiltrating tubular carcinoma. What was going to be a breast conservation surgery for her turned out to be a mastectomy. So we changed the management of this image. Another case of a 53-year-old female presented for routine follow-up. She had no focal lesion seen on a 2D, but on a 3D, we kind of saw something speculated, very, very faint. We were not too sure what's going on. Looking at the density of her breast, we thought, let's just put her for a contrasted mammogram. Even a focus enhances. So this is what we call a focus of enhancement. So that's an architectural distortion showing a focus of enhancement, which is quite amazing for contrasted mammography. So it turned out we managed to isolate it on the ultrasound, and it turned out to be an infiltrating carcinoma. This is another case, a 60-year-old female on follow-up for 12 years post-surgery for left DCIS. It's a very interesting case because she was my boss's very close friend. So that's why he was a bit scared about her, because she noticed that the speculation around her surgical site was increasing. 12 years she was being followed up, and this speculation around her surgical site was increasing. So he said, okay, you know what, your breast is heterogeneously dense, I don't want to take any chances. Let's just do, and you see, if you can see, the 3D shows more extensively the speculation around her surgical site. And we did a contrasted, but what did we find? We found a lesion on the right side. And then we thought, oh my goodness, what's that enhancing on the right? And we went back to her imaging to the right breast. That's her 2D. We didn't see much. Her 3D, it looks like there's some amount of distortion, which actually we missed. And it enhanced. We went back and did a second look ultrasound, found a very vague hypoechoic lesion in that area. We biopsied it, and it turned out to be an invasive ductal carcinoma. So now how lucky she was that we were more worried about the left side and found something in its early stages on the right side. So this was a rather interesting case. This is another case, a 45-year-old presented with a mass in the left breast. These are the cases that we've done in HKL. Those were the ones that we did in Italy, and this is the HKL cases. So as you can see, I think even you can see that there is an area, this is the area that's corresponding to the palpable lump. There's an asymmetric density in that upper outer quadrant. And but I don't know if you can see it, but if you look closely, there is a linear distribution of pleomorphic calcification seen in the right breast. So we were not happy with that calcifications, and her breast was rather dense as well. We were wondering whether we were going to miss, the ultrasound was a bit, a few hypoechoic lesions here and there, so we were not too sure what we were dealing with in this patient with all these calcifications, mass, etc. And look at what we find. We found an area of non-mass enhancement associated with the speculated, with the pleomorphic calcifications in the right breast. We found enhancement of another lesion posterior to the palpable lesion in the left breast. And this is what I wanted to show was, this is calcifications on 2D and calcifications on contrasted. Calcifications are bright on 2D, but on contrasted they are dark. So it makes it a lot easier to see the calcifications in relation to the non-mass enhancement that you get in contrasted mammography. So it's a very interesting case because she turned out to be, the right calcifications were an invasive carcinoma of no special type with DCIS, and the left breast mass was an invasive carcinoma of non-specific type. So this is another case, a 62-year-old female presented with the left breast mass. We can all see the mass in the left breast. And so that was the mass. We did a contrast. We noticed a small little density in the right breast and the upper outer, but we couldn't find it in ultrasound. We did an ultrasound, we managed to find the lesion after the ultrasound. There was an intense enhancement of the focus on the right side. We did a biopsy and it turned out to be bilateral disease in this case. She had a left breast invasive and the focus was also a invasive carcinoma. This is a 45-year-old woman with a biopsy confirmed HKL now. If they have breast conservation surgery planned, they send them down to us to do a contrast. That has become a protocol that we do a contrasted mammogram for the patients prior to surgery. So she was admitted 1 day prior to her surgery because they wanted to do her surgery fast because she's just 45 years old. And 1 day prior to her surgery, they admitted her, they called me, said, can we do a contrast? I said, let's do it. And we did a contrasted mammogram for her. So we found the lesion enhancing. We also found another lesion 5 centimeters away from her index lesion. And it was really difficult, but I managed to find this little hypoechoic lesion on the ultrasound after a lot of measuring, and we isolated this lesion, and it turned out to be an invasive. The pathologist called me 2 days later and said, I had to of course call the surgeons and say I found a lesion 5 centimeters. We postponed her op, and 2 days later the pathologist messages me to say that it was an invasive ductal carcinoma in the new lesion that we had biopsied. So it changed the entire management. We would have just taken out the index lesion and left 2 other lesions in the breast. So, in conclusion, contrast-enhanced digital mammography is a new and promising diagnostic technique with better sensitivity than digital mammography. It has sensitivity and specificity that is comparable to MRI in all the studies that have been done. It comes with a lower cost as compared to MRI. It is a shorter duration of time, 10 minutes compared to 30 to 60 minutes of an MRI. It is more easily accessible, and it does not have to deal with MRI contraindications. So contrasted mammography, we feel, is emerging as a valid substitute to or an alternative to breast MRI, especially in our country where getting a breast MRI for a patient with breast cancer is really difficult. Of course, will be pushed aside in comparison to all the other modalities that we integrate with us. So, thank you.